Greetings and welcome to week 6. This week we're going to look at the breakdown of EM services into categories and subcategories. We're going to learn to define some key terms which are related to EM coding. We're going to determine some various levels of EM codes based on primary and secondary components. And we're going to take a look at 4 types of histories. We're going to be able to contrast 4 types of physical exams. So I hope your interest is piqued, and we'll get started with this lecture. Talking about categories and subcategories of EM services. EM services, or evaluation management services. This physician services commonly associated with doctor visits, in which your doctor takes your patient history, performs a physical exam, determines the cause of your problem, orders and interprets appropriate tests, decides on necessary treatments, and monitor you for changes in your health status. So we also talk about consultation. This is a type of service that is by a physician whose opinion or advice is requested by another physician. In other words, if your doctor wants to bring someone in who is a little more advanced in whatever he thinks is happening with you, then he will call a consultant, or call another physician, or consult another physician. You can also, as a patient, ask for another physician's opinion, which is a form of consultation too. Critical care. This is delivery of medication or medical care to a patient who is critically ill or injured. Evaluation and management codes 99201 to 99499 describe a broad range of physician services. So you're not stuck in sort of a short box. There's a wide range of physician services, and they describe services commonly associated with a doctor's visit. Selecting the appropriate code to describe the services is more complex than determining the correct code to describe surgical procedures. Categories of EMS services are based on the setting in which the services are provided. The initial question that a coder needs to ask is when reporting an EMS services is where were the services provided. Several categories of EM codes are commonly provided in the same setting. Criteria used to determine the appropriate level that should be reported for services are often similar among these categories. And some EMS services are provided in settings other than physician's office, hospitals, including nursing homes, domiciliary, rest home, or in your own home, or in the patient's own home. Subcategories of the EMS services. So secondary factors divide EM services into subcategories. Now, these factors are depending on the setting in which the services are provided. Not all secondary factors apply in each setting, so you have to remember that. And usually 1 or 2 secondary factors determine the correct subcategory. EM codes have a similar format. They have a unique CPT code number. the type of service or place in which the service is provided, the content of that service, the type of presenting problem usually associated with a particular code, the time typically required to provide the particular service. Let's look at key terms in EM coding, such as new versus established patient. New patient. This is one who has not been seen by the physician or another physician of the same specialty within the same group practice during the previous 3 years. An established patient is someone who's been seen by the physician or another one in the same specialty within the same group practice during that 3 years. Excuse me. We have a chief complaint. This is a brief statement that describes the reason the patient's in the office to see the physician. Maybe a symptom, condition, problem, diagnosis, or any other medical reason. Concurrent care. This occurs when there's 2 or more physicians provide care to the same patient on the same day. So in other words, your doctor sees you and he can get you in the same day with someone who is a specialist in what he sees happening. That would be a situation there. Transfer of care. Transfer of care occurs when one physician who's managing all or some of your patient medical conditions gives that care over to another physician who agrees to accept responsibility for providing care for the conditions. We also have counseling. Now, for the purpose of EM coding, the term counseling does not refer to psychotherapy or similar treatments. And when used in the context of EM coding, counseling describes decisions with a patient and or family regarding aspects of the patient's medical situation. We have to have family history. Family history is a review of the medical histories of family members such as parents, siblings, children. That includes their health status or cause of death. It includes diseases in family members related to the chief complaint, a present illness, or a system review. History of present illness. This is a chronological description of the patient's present illness from the onset to the present, so from the beginning to where it is now. Description usually includes the signs and symptoms associated with the patient's condition. Nature of the presenting problem. The presenting problems, the disease, the illness, injury, complaint, sign, symptom, or other reason for the encounter with or without a definitive diagnosis. Now, there are 5 types of presenting problems associated with EM coding. You have minimal, self-limited or minor, low severity, moderate severity, and high severity. We also have to look at past history. This is just a review of the patient's past medical history, which includes major illnesses, injuries, operations, hospitalizations, medications, allergies, immunizations, and dietary status. And if you think about it, every time we go to a doctor's office, we have to fill this out. Review of systems. The review of systems is a series of questions regarding body and organ systems designed to identify signs and symptoms that the patient is experiencing or has experienced, for that matter. We do a physical exam. Now, this is just a little process in which physician or any other healthcare provider assesses a patient for the presence or extent of an illness or injury. Then we have medical decision making. Well, this involves the physician's consideration of all available information. How complex this process is would be determined by the number of possible conditions, the amount of information reviewed, and the risks to the patient or complications that may be a result of those decisions. We need social history. This is just a review of the patient's non-medical information. Time. Time is an explicit component of most EM services. Each EM code that includes time specifies an average time associated with that service. Because this is an average time, the actual times associated with service can span a range that includes more or less time than specified. The total time to provide a service includes pre-service time, in-service time, and post-service time. We also look at unlisted services. Two codes are used to report EM services that are not identified by a specific CPT code. We have 99429, which is unlisted preventative medicine service, and 99499, which is unlisted evaluation and medical service. Special reports. These may be used to determine medical appropriateness of an EM service, especially for unlisted services. Information in the special report should include an adequate definition of the services provided. Selecting the level of EM service. How do we do that? Well, we need key components. Three components of the EM code are descriptors, history, physical exam. These are the descriptors. History, physical exam, medical decision making, and they're used to define the level of the EM service provided. We need to know about care coordination or organizing a patient's care with other healthcare providers. Contributing components, counseling, care coordination, and nature of presenting problem as they relate to EM. Now, if you remember back, we said counseling, we're not talking about psychoanalyzing. It's an entirely different counseling. The category of EM services usually is designated by the location of the patient when the services are provided. Each category includes 3 to 5 for levels for reporting purposes. Selecting the most appropriate level to report EM services is one of the most difficult tasks coders perform. It's a lot of work. The EM code descriptors include up to 7 components used to define the level of EM services provided. The first 3 components are key components used to determine the EM level. The next 3 components are contributory components to the determination of the level of the EM service. And that last component, time, is a variable during those EM services. Excuse me. Okay, let's talk about working with histories for a moment. Problem-focused history. This consists of a limited history of the affected body area or organ system. Then we have what's called expanded problem or focused history. This is a limited history of the affected areas or body systems and other related systems. Then, of course, we have to have a detailed history. This is an extended history of the affected body areas or organ systems and other related systems. Then we have, of course, comprehensive history. This is an extended history of the affected body areas, organ systems, and a complete review of other systems. And then, of course, we have what we call PFSH, or past, family, and social history. This includes information regarding the patient's past history, medical history, the family history, social history, and is a factor in EM coding. There are 4 types of patient history. Each type has its own requirements and determination that differentiate it from others. As we said, it was problem-focused history, expanded problem-focused history, detailed history, and comprehensive history. Some of the elements of history. The history of present illness, or HPI, is a chronological description of the development of the patient's current problem. A brief HPI usually includes 1 to 3 elements, and an extended HPI 4 or more elements. The review of systems, or ROS, results from a series of questions that identify the signs and or symptoms that the patient may be experiencing. Now, there are 3 types of ROS, 3 different types. You have a problem pertinent ROS, an extended ROS, and a complete ROS. The PFSH group, or family, past, family, and social history, includes information regarding all 3 of these areas. Pertinent PFSH includes at least 1 specific item from 1 of the 3 history areas, and a complete PFSH includes at least 1 specific item from either 2 or 3 of those history areas. And for the purposes of EM coding, when talking about physical exam, we have 4 types of those. We have a problem-focused physical exam, an expanded problem-focused exam, a detailed exam, and a comprehensive exam. All of this, if you've been listening and looking at your book as I go over this, realize that there's a complexity of medical decision making. It includes establishing a diagnosis and or selecting from among treatment or management options. You have 4 types of medical decision making. You've got straightforward, you've got low complexity, moderate complexity, and high complexity. The type of decision making depends on the following elements: the number of possible diagnoses or treatment options, the amount and complexity of medical records, diagnostic tests, and other information that has to be reviewed and analyzed, and the risks of complications, such as morbidity, mortality, or comorbidities. When selecting the correct level, each section or subsection of EM codes has different requirements for the levels of EM codes in the section. Some sections require that all 3 components meet or exceed the requirements for the level of EM services selected. Other Selections only require that 2 of 3 key components meet or exceed the level of EM services selected. The determining requirements, or determining coding requirements. Each category and subcategory of EM codes identifies how many key components must meet or exceed the requirements for the levels of EM services in that section. In general, the first time a healthcare provider sees a patient, all 3 key components must meet or exceed the requirements for the level, the selected level. For established patients or subsequent days of service, it usually is only necessary to meet or exceed requirements for 2 out of the 3. And when patients are seen in an emergency department, all 3 key components must meet or exceed the requirements of EM code the EM code that you've selected. There's also special situations. In some instances, counseling or care coordination is the major service provided. Face-to-face defines this component in the office or other settings, whereas unit or floor time is used in the hospital or nursing facility setting. This includes time spent with other individuals responsible for the care of the patient or those having decision-making authority, whether or not those others are family members. Excuse me. I hope this has given you a little insight. I just want to hit upon something. Remember, the 4 types of complexity of the medical decision making are straightforward, low complexity, moderate complexity, and high. They're differentiated by number of diagnoses or treatment options, the complexity or the amount of data to be used, to be reviewed, and the risks of the complications and morbidity or mortality that may result in those decisions. As we stated a little earlier, it's a process. It's not just oh, let me look up this number. It's not like that. So it's going to take a little work. Make sure that you read your chapters. Make sure that you look over what we talk about in lecture and everything that we don't talk about in lecture, because it's all important. Make sure that you don't just glance over it. I want you to look at it and study it to learn, not to just put it in there and then put it on paper and forget about it. You can't do that. This is an ongoing process. So, have a great week. Study hard. Be happy. And I'll see you next week. Thank you.